Hi, everyone. My name is Carol Drexel, and I am a VP of Patient Education at PlatformQ. I am joined today by Dr. Green, who is going to be talking about outcome from an educational activity that we have performed on CGRP blockade in migraine. The educational activity was funded by unrestricted educational fund from Alder Biopharmaceutical, Allergan, and Teva Pharmaceutical. This data should have been presented at AAN this year. However, the meeting was canceled. The data are going to be available online on AAN, but we wanted to make them available to you through this poster presentation with Dr. Green. Dr. Green, please be my guest.
Dr. Mark Green, and I'm a professor of neurology and director of headache and pain medicine at the Icahn School of Medicine at Mount Sinai in New York City. So the first question is, why are we talking so much about CGRP? I think it's important to remember that migraine is a phenotype, and it's caused by multiple genotypes, probably, and doesn't have one cause, any more than diabetes has one cause, and hypertension has one cause, and asthma has one cause. So people in drug development have struggled to find a final common pathway that leads to migraine. Well, it's well known that cerebral vasodilatation plays a role in migraine, and in the past, those in drug development developed vasoconstricting drugs, which in retrospect were less safe and had more side effects than our existing therapy. So to date, the closest we've come to this final common treatment pathway has been CGRP. And if you give CGRP intravenously to a person with migraine, they get a migraine. CGRP, unlike the old drugs, is not a vasoconstrictor. It simply prevents vasodilatation. Also remember that our existing therapy prior to these drugs had a very high rate of discontinuation due to lack of efficacy and certainly side effects. So this educational program was developed to address the knowledge and the practice gaps in the application of these recent advances in migraine management, which certainly include advances in CGRP pathways.
And the educational program was available on PlatformQ platforms, NeuroSiri Live and PenCare Live. The next slide is going to show you some basic information about the activity and our methodology for outcome. The right panel, you can see the information about the activity regarding the format. It was a 1-hour video CME activity, which was produced and broadcasted live online. And then it was available online for 12 months after the live portion. The activity included downloadable educational slides, a panel discussion, live polling, and Q&A. Then follow that, you have some information about our activity, which you are hearing now. Dr. Green was a part of, and then the learning objective for your reference. On the right side, you have the methodology that PlatformQ employed to measure the outcome of the activity. It included a pretest to measure baseline knowledge and competence. Then the learner engaged in the activity, either live or on demand. Then they took a post-test to measure immediate changes in knowledge and competence and the evaluation for CME. And then it was followed by a 2-month follow-up survey to measure retention and application in practice. Here are demographic information about our learner. As you can see, there was over 1.1K total learner engaging with the activity, and 80% of them were MDs and Ps or PS. But now looking at the real interested target audience, which is the target audience that we were really going to, which were neurologists, headache specialists, primary care, internal medicine. 70% of them were part of the target audience, which is excellent. On the right panel are some example of engagement numbers. 299 CME credit awarded, and 166 total slide download. Next, we are showing you some data on clinician-reported impact on patient outcome. 84% of the clinicians who participated in the activity reported a positive impact on patient outcome, and 49% gave specific example. And you can go through them yourself, but I'm going to just read a few with you. So some said, patients are experiencing reduced side effects. It mainly helped me better counsel my patient. Patient now experience a better cure with less headaches per month. So these are just some examples on patient outcome. The next slide is going to look at example on actual physician practice. 83% of the clinician reported a positive impact on practice, and 55 gave specific example. And some of those were, I have increased my use of different CGRP medication. I am now better able of identifying patient early. I'm more confident in dealing with chronic migraine patient and dealing with a new anti-CGRP treatment. So these are some examples, and Dr. Green is now going to give you some expanded explanation about some of the pre, post, and follow-up survey that we found.
Well, I'd just like to address a couple of them. As I already said, side effects are one of the features that have led to significant discontinuation rates with many of our preventive migraine drugs. So an example of this, look at the one on the left, is what drug is best avoided in a migraineur with comorbid anxiety? And the answer is topiramate. Yet only 31% answered correctly in the pre-test, but it rose to 49% in the post-test, but interestingly, rose even higher to 56% in the 3-month follow-up, as practitioners, I think, became increasingly aware of this very prevalent side effect in their own practices. Another example is what is chronic migraine, which had a dramatic post-test improvement. You need to know that only botulinum toxin A, and then more recently, the CGRP monoclonal antibodies, these are the only drugs that are FDA approved for chronic migraine. So it's very important for practitioners to understand the criteria of chronic migraine. So overall, the evaluation data that we are presenting has shown a positive impact on this online educational program in terms of improving knowledge and showing, most importantly, clinical impact. Results of this educational evaluation, as well as the learners' submitted questions that are pointed in the bulleted areas that you see on the poster, these are strong targets for future educational efforts. An example of what these future educational efforts might address: one, what role does CGRP play in the pathophysiology of migraine? And most importantly, what role do anti-CGRP drugs play in migraine prevention? Another is, how can you switch, and is it rational to switch between CGRP monoclonal antibodies if one fails? And finally, how are the side effects of these drugs, if present, how can they be addressed? So I'd like to thank everyone for participating in this program, and I'd also like to thank our sponsors for the program. Thank you very much.